Heart disease kills one person every 40 seconds. That number hasn't changed in 30 years. Dr. John Osborne, a preventive cardiologist with 2 doctorates and 29 years in practice, has spent his entire career on a single question. Why do we screen for cancers that kill a small percentage of us and do little to detect the disease that kills 40% of us? In this episode, we talk with Dr. Osborne about the imaging technology that can detect early signs of heart disease years before symptoms appear. If you track your blood work, wear a fitness device, or consider yourself relatively healthy, this conversation will fill the gap nobody warned you about. This is Brobots, the podcast that tries to help you be a better human by being smarter about how you use technology.
Today we have Dr. John Osborne with us. We are going to talk about some interesting topics when it comes to AI and understanding your health in the proper context. So, Dr. John, you want to give us a bit of an intro about yourself?
Yeah, sure. So, John Osborne, I like to say trained in cardiology, but really my passion is preventative cardiology, which is really what I've been doing for, this will be 29 years in cardiology practice. So almost 3 decades worth of that. And really started out from the very, very beginning. I got my MD, I got a PhD in cardiovascular physiology. So I'm quite the dweeb, the nerd. Then did all the rest of my training up at Harvard at Brigham and Women's Hospital. And there I really got very excited about how do we identify people who have heart disease literally years before they get in trouble, years before they have symptoms, flunk a stress test, before they need stents or balloons or bypass surgery. Because if you think about it, and a really pretty good analogy is why we do colonoscopy, right? You ask anybody, why you do a colonoscopy? No one likes it. It's expensive. It's tedious. You got the nasty prep, et cetera. And yet we all should because we want to find the polyps that can, over time, without any symptoms, turn into colon cancer, and we don't want that to happen. And we do that. We do that routinely. Uh, More people need to do their colonoscopies, by the way, out there. Uh, but the goal is that we help to reduce, and I would argue, hopefully, eliminate colon cancer. Let's find the early stuff. You take care of it, bad things don't happen. And for some really weird reason, and by the way, colon cancer kills 2 to 3% of us in the US, okay? Which is 2 to 3% too high. Heart disease kills about 40% of us, strokes and heart attacks. And what do we do to identify the disease early when it's very, very treatable and preventable and reversible before you need stents or balloons or bypass surgery or have a heart attack or stroke or, like many people do, simply keel over dead?
So
Nothing.
one of the things that's fascinated me about this and reading and studying about you is how you're integrating technology and to making this faster, making it more efficient to be able to
Mhm.
save more lives. If you don't mind, sort of lay the groundwork there of like how you're using AI, how has technology helped you to literally save lives?
Sure. So when I started out 30 years ago in training cardiology, where you learn how to read EKGs, do stress tests, heart catheterizations, all those things, and I'll argue, and hopefully I'll make this point as we talk about the technology we use today, that most of those technologies are irrelevant. They're 20th century technologies, I like to say,
Or maybe
right?
19th century technologies with
Well,
EKGs?
yeah, exactly, right? I agree. And yet, if you go to most cardiologists right now, that's what you're going to get: EKGs, stress tests, heart caths, maybe, et cetera. Um, so I've always been very, very interested in how do we identify, and how do we use technology that allows us to take better care of patients, to understand what's happening with them in a much more precise way. So in the 90s, I learned kind of the typical cardiology tools, came out, and about, well, about 3 years later or so, I caught wind of this really nascent technology uh, called cardiac CT. Uh, I basically said, okay, I need to learn that. So I did on the job training. The early technology, I will say, using cardiac CT was extremely crude, low resolution. Software just wasn't there. It was a bear to do and read. And it was hard. But I did that for about four years or so, and I began to see there's incredible promise here. But I really was using what I like to call nowadays the iPhone point 0.5, right? This wasn't even a release iPhone. But I began to see, I did several hundred cases with this cardiac CT technology, and I realized this may be we may be on to finding the cardiac colonoscopy, right? Find the early stuff long before you get in trouble, take it, prevent it, etc. 2005, big year. In 2005, certain devices became commercially available called 64 slice machines. I'll call that the iPhone 1. And that's where the rubber began to meet the road. We did have better hardware, better resolution. There was now some software available. And in fact, it was even so good 21 years ago that before 2005, if you had problems, we did stress tests and I did heart caths. But the very early cardiac CT, again, this is a decade and a half before AI, began to become so good that I could get better data, more accurate data to understand people's heart, find the early, I call it baby plaque, be able to get even better data than a quote gold standard heart cath or an angiogram or cardiac catheterization, and do it without the risk, without the risk of complications, and do it for about 5% of the cost of an invasive heart cath.
That's
So
pretty
and so
amazing.
2005, big year in my life, because that's when I gave up. I like to call it the nasty habit of stress tests and doing heart caths. Completely switched over to cardiac CT, even at the iPhone 1.0 level. That's how good it was. Fast forward now to 2026. We now have the iPhone 17 version of cardiac CT. Unbelievable pictures, beautiful resolution, about 2 magnitudes of order. That's 100 times less radiation than we started out 20 years ago. Um, and stress tests, heart caths, all that, those legacy tools, all that equipment should be in a museum. And we look at it and read a little 8x10 on this is stuff we used to use to figure out if people had heart disease.
So along those lines, I mean, there's definitely training protocols, and people have been using those old tools for a long time, and the manuals have been around forever. They're well documented. They've definitely shown some avenues of success in detecting some of these pieces, but
Sure.
clearly, I mean, I've been on the receiving end where the tools gave me false positives, and all kinds of lifestyle changes had to occur for no good reason.
Right.
And the cardiac CT, in terms of the training, I mean, the technology itself, I know is much better, but in terms of the training, accessibility, where it's at, how to get to it, whether or not the FDA fully funds it and approves it, whether insurance companies fully funds and approves it, I think those are things that people probably have questions about, because the technology
Sure.
itself, I see the value and the benefit of it. But can you speak a bit to the fact that this is, for lack of a better term, more of a nascent technology in the medical space, and the training isn't quite as broad? And if people really want to go into this, are there specialists they have to seek out, and how do they navigate the healthcare system in the US to get to those kinds of specialists?
Yes, well, multi-layers to that question, and
I do
I
that,
will
sorry.
warn. No, that's okay. But I will warn you. Remember, I'm a cardiologist. We have very small brains, so I'll try to tease that apart. Again, 25 years ago, I began to do cardiac CT. Technologies got amazing. AI really kicked in 5 years ago, took
Yeah.
it to a whole nother level. I call it cardiac CT 2.0. And here's what the AI does, right? It allows me to literally see. I can look at these images now with I call it my special AI glasses on, and I literally can see stuff, detail, plaque that we cannot see with our eyes. So that's one major advantage. We can also now quantify that plaque extremely accurately down to a resolution of zero point 0.1 cubic millimeters. So to give you an idea what that is, think of a period at the end of a sentence, turn that into a three-dimensional sphere. That's about 1 cubic millimeter. We have resolution down to a tenth of that volume to see plaque and identify plaque. And then because we can now quantify plaque, which was impossible to do, right? I could see blockages. I could look at plaque and go, yeah, there's some plaque there. I could not quantify it. Now we can quantify the plaque, put it into different categories, because there are different kinds of plaque. We could maybe talk about that later. And we can now track that plaque over time. So it's not just eating right, exercising, taking medication, blood pressure, cholesterol, whatever might be appropriate and personalized and bespoke for that patient to treat and stop and by the way, reverse the plaque, which we can. But now we can literally show I had my scan last year or 2 years or 3 years ago. We did what we needed to do, or on my advice, hopefully, and we put you back in the machine, and we can literally track not just are my numbers better, my blood pressure's better, my cholesterol's better, whatever, but we could literally track and say, yes, your plaque is better. And that was impossible until we had the AI. As far as paying for it, in October of 21, remember I started this 25 years ago. In October of 21, our organizations, the American Heart Association, the American College of Cardiology, another small organization that main focus is cardiac CT called the Society for Cardiac CT, and several others came out with guidelines for chest pain, right?
Yeah.
Chest pain could be heart attack, whatever. They said in 2021, October 21, about 21 years after I started my journey, they finally said that cardiac CT is what we call a class 1A indication. I'll translate what that means. It means that is standard of care.
Yeah.
It's not just a good idea. It's not an option. You could try this. It is now the standard of care for patients where we are concerned when they have symptoms to suggest they have heart disease like chest pain, angina, maybe new onset shortness of breath, or something to suggest they have heart disease, which then means insurance pays for it, CMS pays for it, commercial insurance pays for it. Um, the challenge, though, is for early detection, again, using that concept of this technology as the cardiac colonoscopy to find the polyps long before we have blockages, long before we have symptoms or flunky stress tests. Unfortunately, that is not yet paid for.
Yeah.
Now, we can get it. We do it all the time. But unfortunately, do not expect insurance is going to pay for it just for you to know and understand, do I have plaque or not before you die, okay?
Right.
Or have a heart attack or need stents or bridge surgery. And that's really, we take care of people, across the spectrum of heart disease, people who just want to know, people that have a family history, people that might have risk factors or, do I have plaque or not, all the way to people who've had heart attacks, stents, bypass surgeries, et cetera. So it's unbelievable technology to really understand, is there plaque? How much plaque? Where's that plaque? What kinds of plaque? Quantifying plaque, detecting plaque, and tracking plaque, all the stuff that we literally could not do until we had both cardiac CT now coupled with AI.
Yeah.
I hope I covered some of the questions that
No,
you
you
asked.
you
There
did
was a
great.
brilliant set of questions, but I hope I did justice to
No,
them.
you did great. And realistically speaking, I mean, I'm just Googling right now, where can I get a cardiac CT? And I'm going through and I'm like, how can I do this? I'm looking at the different places I have. I'm in Everett, Washington. So I've got 3
Oh,
different
yeah.
clinics
Great
that have,
place.
I've got,
Phenomenal airplane museum there.
yeah, really, really. I actually live right by
Amazing.
the airplane museum. So I live
Yeah, love
right
it.
across from it. Yeah.
I'm an aviation foamer, they
Oh,
call me.
perfect. Yeah.
Yeah,
No,
it's like having rabies, but for airplanes.
exactly. Yes. But no, so I mean, I'm looking at it and I'm seeing 5 places that do this, and I'm looking at it from the perspective of preventative care, and they all say, like on these splash pages on the websites, preventative care is a good thing, but your insurance probably doesn't cover it. So
Right.
it's not a
Right.
cheap test. And I do DEXA scans all the time for kind of the same reason, right? I want to go through and I want to understand my body composition over time, see what changes I'm making, are they effective. I do blood work the same way. So I track my blood work over time. I see what supplements I take, what different patterns and exercise routines I have, what my sleep schedule looks like. I mark that and track it over time. It makes sense that the body's plumbing system should probably be part of my routine in my scan to go through these pieces, which, I'm fortunate enough that I can afford to go out and spend. It looks like these tests are somewhere between $1,200 to $2,500 for when I go take them for a series. So I can afford that. Most people can't. But that being said, are there smart things if somebody can go through and they can do like 1 or 2 of these tests, they actually find plaques that are built up?
Absolutely.
What are the treatment protocols that you start looking at in terms of being able to go through and take these different plaques out? And I know that like all the different types and sizes of plaques and going through and measuring those pieces over time and trying to look at, different lipid profiles to understand how those things kind of get glommed on. What is the general information that you give when somebody pops up and they say, oh, you've got plaque in your arteries, your mid-30s, mid-40s, and we'd like to do these things more preventatively? Are there certain protocols that you recommend just in general that we're not doing well today? And do you have general protocols that are recommended for sedentary Americans who sit around on their computer all day in their mid-50s?
I've never heard of such a thing. What are you talking
I'm just
about?
saying.
Who does that? Who does that? So it's a theoretical question.
Yes, in theory. In theory.
Asking for a
let me
friend.
tell you something I think is out there right now. We've been doing it for 40 years.
Yeah.
It is very mature, very accessible, takes just a few minutes, no prep, no IV, no fasting. You literally show up and is very, very affordable, right?
Yep.
So I will say, consider this the mammogram for the heart.
Yeah.
By the way, and again, I want to be careful for you and the audience out there. I don't want anyone to say, well, geez, Dr. Osborne's saying heart disease is more important than any other disease. I'm pretty much anti-disease, okay? But heart disease is what I do and specialize in. And it is interesting, since I did mention mammogram, more women, to give you an idea of the terrible burden of heart disease that's out there, more women who are diagnosed with breast cancer will die of heart disease than the breast cancer. In fact, 10 times more women every year, year in, year out, will die of heart disease, strokes and heart attacks lumped together. It's really quite similar, really. And the strategies to prevent them are almost identical. More women will die of strokes and heart attacks of cardiovascular disease. 10 times more of women will die of cardiovascular disease, strokes and heart attacks, which is detectable, predictable, preventable, than breast cancer.
And this is just because of lack of testing. They're not.
Yeah,
Yeah.
right. Again, the unlike oncology, where we do colonoscopies, pap smears, mammograms, all those tools to detect disease early, and it completely makes sense and all that. And we do it across the entire population for mammograms for women, and we now do, interestingly, low dose CAT scans for people who had a history of smoking or who smoke for lung cancer, where there's a mortality benefit if we find it early, and of course colonoscopies and pap smears. But what's fascinating, each of those knocks off a few percent of us, okay? Heart disease kills about 40% of us, and what do we do to find it early?
Almost
Nothing.
nothing.
Crickets. Yeah.
Yeah.
However,
That I was going to say, like,
yeah,
I
nothing.
feel like we mostly just rely on blood work, right? If the blood
Right.
work looks good,
And
then everybody's
here's
healthy
the
and they're going to live a
problem.
long life.
I will argue there is no blood work right now, and I don't even see it coming out in the near term, where I can say you have plaque in a binary 0-1 way. You have plaque, how much plaque, where it's located, is it risky plaque, is it non-risky plaque? I do not see that coming in the next several years. Maybe further, science is amazing, but I don't think we're going to learn it from a blood test, because we're simply sampling your blood. It tells me nothing about, is that cholesterol sticking and getting into your vessel wall. Right now, and I think for the foreseeable future, the only way we're going to do that is with imaging.
Yeah.
We need to literally image the vessel. Just like colonoscopy, yes, there's Cologuard. You send in a stool sample. There's a new test you may have heard about, just came out, which is a blood test for colon cancer. That's great. However, you're still not looking directly at the colon. You can miss polyps. You can still miss colon cancers because you're looking at indirect measures. I would argue we need to directly look at the blood vessels to see if you have the disease, just like we directly look at your colon to see if you have polyps or cancer.
Right.
But I was going to say, there is a phenomenal tool we've been using for 40 years, cheap, easy, accessible in most all communities, not just in the US, but really worldwide, which is a coronary artery calcium score. Okay. Not as sophisticated, not as amazing as cardiac CT with AI, but it's a great place to start. I always think of that as sort of the mammogram of heart disease. Takes a few minutes. We do it with a CAT scanner, by the way, not an MRI. So just to differentiate, sometimes people confuse those. The MRI is the coffin or the tube. They stuff you in there. CT is just the big donut. We call it the donut of destiny. So you get in the donut, takes a few minutes, no prep, no IV, no contrast. You literally show up, takes a couple minutes to do it. Some places will actually give you the results right then, hot off the press. And what you're looking for is a 0 score. So this is the case where everybody wants to be a 0. Okay. If you're 0, phenomenal. If you're not 0, that is, we see calcifications building up in the vessels of the heart, that means you have plaque, 100%. Buck stops here. Now,
Probably because of all the donuts of destiny that they ate to got them
probably,
into that
yes,
position.
that 12 pack, that they just had that morning. But it is very accessible. I'll say generally about $100 plus or minus. I've seen as cheap as $43. And I think that's a great place to start. Now, it's not a perfect test. You do have false negatives. You can have people that have what we call soft plaque or lipid-rich plaque, okay, that does not have calcium in it, that can still get you a 0 score. That's between 10 to 50%. Okay, 10, 250. Uh, but a 0 prognostically is very good over the next few years. Uh, the other thing is once it's not 0, yes, you have plaque, but you have no idea. You've now seen the tip of the iceberg.
Yeah.
How much is calcified and visible on a calcium score, because it's a calcium score. By the way, not a blood test, by the way, it's done with a CAT scanner. And how much is the lipid-rich, soft, or cholesterol-rich plaque? That's really the active plaque, okay? I called the hard plaque, the calcified plaque, that is the volcano, that is the cinder cone, right? You know there was an eruption, there was lava, but you have no idea about the lava aspect, how much lipid-rich, soft plaque that would be invisible. When we do cardiac CT, much higher resolution, we use AI for that. We can see the whole cardiovascular enchilada, and probably
Uh,
the enchilada you just had showing up in your blood vessels. But there we see hard plaque, soft plaque, blockages, narrowings, plus lots and lots of other free data. In fact, I'll tell you, you mentioned DEXA. We now have software that just got approved in December where we can take your cardiac CT study, that same data, send it up the cloud, and do your DEXA scan off that,
yeah.
and come up with your Z scores and T scores and all that. So no additional scanning. The data is already there. We just extract it. We
Yeah.
can also extract a huge amount of other values from that scan: liver fat, lung abnormalities, lung nodules, all kinds of crazy stuff we can now extract from that same scan, so that we leave no data behind.
So let me ask you about access to this testing. I live in Canada now, so I could literally go into my
Oh,
doctor's office and
okay.
tell him, "Can I do this?" And he'll go, "Yeah, here's go do the thing, and I'll be fine." I imagine when I lived in the States that it would have been a bigger hill to climb to be like, "Bloodwork's clean. Can I get this test anyways?" There would probably be some pushback and like, "Well, why would we do that? Like, there's no red flags here. Why do it?" Can literally anyone just say, I'm concerned about this and want this test?"
So I am not an expert on the Canadian medical system. I know it's a little more uh,
No, I'm more concerned about the
rigid,
U.S.
but
Where I would
oh
imagine it
yeah,
would
in
be
the
harder. Yeah.
US, yeah, I mean, absolutely. You might have to pay cash if you have no symptoms. But relative to the information you gain, 40% of the deaths are due to plaque. I think it's a pretty good investment, right? So yeah, absolutely. Now, if you
So,
have
but
no symptoms, yeah,
oh, I was just gonna say, I'm also curious about the AI part of this, right? Like,
yeah.
we're all on board. This sounds good, but I can just hear the skeptic out there that's like, that thing gets it wrong half the time. How
Yeah.
much can we trust that the AI is getting this imaging right and
So
giving us the right information?
Yeah, so to get in the weeds, the AI has been calibrated and validated across multiple different ways of measuring and looking at plaque. We've used something called intravascular ultrasound, where we literally do a heart cath, put a tiny little wire down your vessel, put a ultrasound transducer over that. So it's very expensive, very tedious, very invasive, and then measure the plaque. Okay. It has been useful over the last few, 20 years or so to allow us to test drugs to see, does a drug in 100 people, not 10,000 people, but 100 people, does that drug over time shrink the plaque? The problem is very expensive, tedious, and about, not surprisingly, you can imagine, because it's invasive, heart cath, putting wires down your heart, all that stuff. About a third of the people in these drug studies to see, does this drug help to stop or reverse plaque? A third of the people going through it once would not show up the second time because they're going, I'm not going to have you put a catheter in my heart, in my groin, in my heart, blah, blah, blah. Screw this, right? We can now, the cardiac CT and AI has been validated against that. So we've calibrated and validated against IVUS. Another tool called optical coherence tomography, another extremely high resolution way of looking at plaque. Again, an invasive test. We can now do it non-invasively. Also something called infrared spectroscopy, where we can really measure and detect the lipid cholesterol plaque. Again, it's been validated against that. It's also been validated against what we call quantitative coronary angiography. That is actually taking micrometers to your angiography and measuring changes in plaque. So it's been validated against all of those different ways to be accurate. So, and I find, again, I've been doing this for 25 years. When I look at the studies, having read 25,000 of them, and then look at the report that the AI generates, I have to say it's really, really good. It's very on target.
Yeah, I mean
I
the
won't
the
say it's better than me. but it's really good.
Well, but it's going to be really good at taking large macro sets of information, and if you give it enough clue information, it's going to be able to go through and give you a pattern. And that pattern, if you're
Exactly.
accustomed to it, it can say, "Hey, look deeper here and trust human eyes to go in to dive into these levels." But I mean, human beings, we tend to look for red flags and green flags, where the AI can go through and be more discerning to that and say, here are a bunch of yellows that maybe you just skipped over because your brain is looking for the reds. And
Exactly.
I
Yeah,
work in tech
true.
and I do this all the time, and I'm either debugging code or looking at packet traces. Like, this happens all the time, and human nature is to kind of scan over those pieces, and the AI provides that extra level of oversight and really assurance that you've actually covered those bases. And from my perspective, you guys have been doing this a long time. The training data to do this is probably relatively simple, because the composition of human bodies it's not unlimited, but it's very wide. But when you get down to actually going through and focusing on something that gets down to the size of a period, the amount of pixel information you can actually extract out of that to understand it is pretty distinct. So telling you these things are hard and soft and how they're layered in is probably a technique that's the AI is kind of perfectly designed for, to be honest.
Oh,
Um,
and I
yeah,
think too, what the AI does, I would argue probably you probably have to do and look at and correlate with cath, as I
sure.
did when I first started 20 years ago, at least 1,000 to 2,000 scans till you
Yeah.
start getting good,
Yeah.
right? What AI does is democratize it.
Yep.
Because you can take someone who's not done 2,000 scans, you send it up the cloud, does the processing. It's very accurate to look at blockages and narrowings, as people worry about that, or stenosis, as we call
Yeah.
it. And then more importantly, though, is actually plaque volume, hard plaque, soft plaque. It is really, really accurate. And I can vouch for that. So it really democratizes the scan and the scan data, where you can have somebody who's a primary care doctor
Yeah.
order it, get the report back, which is very important and very actionable, without having to be a CT expert, which is great.
Yeah. And I
So,
mean,
yeah.
comparatively, I mean, I'm looking online at clearcardio.com, and I'm looking at scheduling my appointment and everything else, and the cost value associated with it. It's substantially cheaper. I mean, it's like the cost of 4 of my DEXA scans, which if I get a
So,
DEXA scan for free, that's fantastic.
all right, I'm going to tell you guys something,
Yeah.
and your audience. This is a little secret. I, I've never told it outside of our organization, but I think you'll appreciate this. And I hope it's not in bad taste. But one day we're sitting around, eating and drinking and having great wine, and we go, here's what we charge for our stuff, which is not just the scan, not just the AI, but it really is also the plan
Yeah.
customized to you to stop you from having heart attacks, right? So it's really all of that together, right? We're not a scanning operation. We're a disease detection, prevention, and treatment organization. We do
Comprehensive
all of
care.
that, right? But we're going, okay, here's the price we charge, which we do try to keep, I think, reasonable for what we offer. Uh, I think our value proposition is high, but we said, you know what? About the same cost as our whole experience. So you get the scan, you get the AI, 6 months to 12 months of my tweaking things and discussing and blah, blah, blah. It's about the same cost as a casket. So cardiac CT or casket, about the
It's
same price.
it's
You
also
you make
cheaper
the
than
call.
dinner at French Laundry. So
Oh yeah. Oh yeah. Exactly. Yeah. Yeah. And
once in a
nice
lifetime
memories. Yeah.
culinary experience, or once in a lifetime cardio experience. Make your decision.
Right. 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 And we really do try to make it as accessible as
Yeah.
possible for everybody, because my ultimate goal along the way, save lives, make sure you guys don't have heart attacks, strokes, preventable stuff, right? But really my goal is to eliminate heart disease. And I think we have really great proven tools in our toolbox to treat and stop and reverse plaque that generally has been used in people with extensive extreme plaque after a heart attack,
Yeah.
after a stent, after bypass surgery. We know it works. And you do these things, and it means less strokes, less heart attacks, less balloon stents, bypass surgery. Our major failure in cardiology is we've never had that screening program, like your colonoscopy, or here, like your cardiac colonoscopy. So we're missing massive numbers of people to prevent their heart attacks, their strokes, their balloon stents, or bypass surgery. But also, in half of men and 2/3 of women, the first symptom of heart disease, the first time you know it, you die from it.
Right.
We make the diagnosis from your toe tag, and we go, "Oh, yeah, there was a heart attack." Wish we'd known that a year before, 5 years before, 10 years
Yeah.
before, when we had very, very effective tools to literally stop and reverse it.
Yeah, I mean, all dead people have one thing in common: their hearts have stopped. I
Yeah,
mean, it's 100% of dead people have hearts that
yeah.
stopped. Not
Cemeteries,
100% people's hearts stop have cancer.
absolutely, and I will say, you know, heart disease kills 1 person every 40 seconds, and
Yeah.
unfortunately, when I started 30 years ago, 1 person died every 40 seconds of heart disease. 30 years
Yep.
later, 1 person dies of heart disease every 40 seconds. We've not budged that number.
Yeah.
Um, and one of my favorite surgeons years ago, cardiac surgeon, said, "You know what? Cemeteries are full of people not having birthdays," to
Yeah.
echo what you just said.
Yeah.
So,
I wanted to touch on what you mentioned a minute ago, the plan that comes out of all the scanning and investigating and finding the answers. Are there common threads that for anybody, scan or not, right?
mhm.
I'm 40, 50-year-old man. There's probably some things I could be doing better, scan or not, to make sure that my heart is healthier or doing better. What are the common threads that you see that are the most effective for most people, generally speaking?
Sure. And I wanna be this is very positive. I mean, I love preventive cardiology. Um, 50% of your risk, so if you take people at very high genetic risk, right? They chose the wrong ancestors, I like to say, but they do very, good lifestyle stuff, right? Mediterranean diet, eat right, exercise, do all that good stuff, don't smoke, probably minimize or even eliminate alcohol, blah, blah, blah. You do all that stuff. 50% of your risk, even with high risk patients who are at high risk because simply they chose the wrong ancestors, they chose that they had bad genes, 50% of that risk could be modified with lifestyle. So Yahoo, it's tremendously effective. Now, the problem is the other 50%, you chose the wrong ancestors. But
Yeah.
we can fix that. We have really effective tools, and I've got a very large toolbox, I like to say, and I'm talking about tools, that we can use that have been proven to stop and reverse plaque. The problem again is we always use it 20 to 30 years after the disease started because it has a really long asymptomatic phase, right? So, yeah, to your point, it's not complicated. Move every day, get your heart rate up, get hot and sweaty. I think people get really involved with what kind of exercise, treadmill, elliptical, cycling, right, running, biking, aerobics, resistance, whatever. All that's great, but keep it simple so you can do it, so it's sustainable because you're going to be doing this for decades. In fact, the more you do it, the more decades you'll have that you can do, fit in your lifestyle, fit into your physiology. People as they get older get knee problems and all that stuff that you can do most days of the week, hopefully every day of the week, but most days of the week, that you like to do, or as I like to say, least to test, right? What you do is not really so much important. It's just moving. Now, if you really want to get into the weeds of it and resistance training and how many reps and all that, sure. But I think many times that sort of really causes most people are, that aren't used to exercising. They go, well, yeah, you got to have the right equipment. You got to do it just right. I need perfect form, blah, 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 blah. And I can't do it. And it stops. So I would say just move, get hot and sweaty, do it for half an hour a day or 10 minutes 3 times a day. It's the same thing that you can do it most days of the week. So I would start with that for everybody.
What about those that maybe it's more the bad ancestors that they've chosen?
Yeah.
Just looking at my own example, my dad has not lived the healthiest lifestyle, but he's 80 years old. My mom is in her 70s, very healthy. Her dad died very young
Mhm,
from heart disease.
mhm.
How concerned should I be that I have this one sort of red flag in my relatively immediately background? Is that something that is cause for concern that I should take this
Yeah,
a little more
family
seriously?
history is really, really critical. Um, and sometimes though it can jump generations, right? Grandfather died early,
Yeah.
mom's 80, right? And also, there are clearly differences between men and female and sexes and things like that. Um, But family history and understand that is really, really important. And I'll give you an interesting little uh, genetics nugget. So you can imagine if you have mom or dad, hopefully not both, but it happens, mom or dad have heart disease, again, stents, balloons, bypass surgery, heart attack, strokes, whatever, all those manifestations of vascular disease. And you can understand that having mom or dad having that, particularly the earlier they have it, the greater risk that you have genetically. However, the greatest genetic risk factor for heart disease is not mom or dad, it's a sibling. So if you have a
Really?
sibling that had a heart attack or a stroke or balloons or stents or bypass surgery or any manifestation of atherosclerosis or plaque, and that's all really at the late stages of it, uh, definitely make sure you get checked out, because the reason I say that is you're only half like mom, half like dad, but genetically you are more
Mhm.
identical genetically than anyone else in the world to your siblings. So if your sibling has a heart problem, please hie thee to somebody who can, you know, do this preventative stuff, or at least hopefully reassure you you're fine. Another factor too, family history. Obviously, smoking plays a big role. So whenever someone says, grandpa, mom, dad, whatever, I always ask, did they use tobacco? In fact, not just smoking. I don't care whether they smoke it, snort it, chew it, inject it, rub it on your skin, vape it, use it as a colonic. Tobacco, nicotine is really, really toxic. Okay. So I don't care how you get in your body, because it will get in your bloodstream. We literally have nicotine receptors on the inner lining of our vessels. And when they get stimulated, they turn your vessels from Teflon, as it should be, into nasty, sticky Velcro. So don't do it.
That's so
So,
interesting because I see like health gurus in this space
oh
that like
gosh, I know
rave about nicotine.
I've just seen that. I mean, this seems to be one of the latest fads. Oh,
Yeah, yeah.
nicotine patches, they're harmless, they're great. No, I think that's my humble but accurate opinion, completely against any science that I've learned over the last 30 years. I got 2 doctorates, 7 boards, been doing it for 30 years. Absolutely 100%. I'm collaborative. I work with people. I'll listen, right? Earth flat? I don't think so. Let's have a
Right.
discussion, right? But
Right.
no, but I will say there's the red line limit. Nicotine in no way has any health benefits. It is
Wow.
addictive. It is a nasty chemical. There's no there. Well, there is one good thing about nicotine. I will say, here's the one good thing about nicotine. So lean in and listen clearly. Nicotine is great because it makes for nice, young, thin corpses.
Smaller coffins, which are cheaper, from what I
And
understand.
smaller
So, you
coffins,
know.
exactly, yeah. So, yeah, no, I've heard that just recently, the whole nicotine thing and blah, blah, blah.
Yeah.
Oh, I just think that's so dangerous, I is
Yeah.
my opinion. My
What about
again, humble but accurate opinion.
what about things like serapeptase and etokinase and garlic and like
Yeah,
all the supplement
yeah,
routes that
yeah.
people offer up? Do those have actually any real benefit?
Um, Let me put it this way, I'm a hardcore scientist, right?
Sure.
I wanna know, is this approach, exercise, diet, drug, nattokinase, whatever, vitamin E, whatever, is it safe and is it effective? 10,000 people, half get it, half don't, double blinded, randomized, placebo-controlled trial, followed over 7 years. That's the level of evidence that will say, "Hey, this is what I'm gonna do or recommend." I understand the benefit. I also understand the risks. Very rarely in the vitamin supplement world has any of that work been done. Most of it
Oh.
is, we gave it to 5 mice. 2 of the mice said, "Hey, I feel good." There we go, right? So that's basically nattokinase. And interestingly, there was one study with nattokinase, a double-blinded randomized trial, 3 years long, fairly small, just a few hundred people. Half got nattokinase, half did not. They were looking at plaque in the carotid, so not events, but plaque, which is fine. I mean, it's a surrogate marker, but to see if that plaque changed over time. No change in plaque, no change in blood pressure, no change in metabolism, no change in diabetes, no change in cholesterol. It was a perfect placebo. So absolutely no difference between placebo and nattokinase. That is the only double-blinded, randomized, placebo-controlled trial on nattokinase specifically. The other thing too, okay, here's a little factor when people talk about nattokinase specifically, and I hate to, you know, pop people's bubbles, but nattokinase is a large protein, right? The idea that this helps to break up clots and things like that, that's great. But nattokinase being a large protein, you eat it, it goes in your stomach, it gets chewed up in seconds by your stomach acid and all the enzymes we have to chew up proteins. We do not absorb proteins whole. We break them down into their constituent
Yeah.
amino acids. There is no nattokinase in your bloodstream. It can't get in your bloodstream. It can't get out of the stomach. So that whole thing, and in fact, there was some recent studies in the last few years where they looked at, and again, I don't want to get the whole statin thing, but just as far as cholesterol lowering benefit, okay? We gave people a low dose of a commonly used statin, rosuvastatin, 5 milligrams, 28 days. It lowered LDL by 39%. Okay, did what it did, no problem. But we compared that to placebo, garlic, uh,
Red yeast rice, something like
fish
that.
oil, red
Yeah.
yeast rice, right? The usual
Yeah.
sort of
Yep.
supplements. Uh, Basically, some of those actually raised cholesterol a tiny smidgen bit, not clinically significant. The only one that actually did lower it by about 5% was red yeast rice, by 5%. All the others, no different from placebo. So again, I'm going to go with the science and the data. I don't want to get into the whole statin thing because, and in fact, I would argue people say all the time, well, are you going to use statins or whatever? I say, let's first of all understand, do you have the disease? Once I know you have the disease, then we're going to talk about a bespoke, customized, personalized program for you to make sure you never suffer the consequences of that disease called strokes and heart attacks and all of that other stuff. And I think people get too much into, well, statins and then, but I got a really big toolbox of tools that are
Yeah.
proven tools that have been tested in double-blinded, randomized, placebo-controlled trials where we really do understand the the proven benefit. You can literally say, here is the benefit. And all drugs have potential harm downsides. And I can say, here's the benefit, here's the things to look out for. Not every drug is perfect for everybody. But again, we have so many tools and proven tools that work at multiple different levels, multiple different mechanisms of action that I would argue if we did a better job in early detection, and that's really the imaging part, heart disease as we know it, we could eradicate it easily within a generation. Easily.
So
This seems like a perfect place to ask then. If somebody does want to work with you and the many tools that you have in the toolbox, how can we find you? How can we learn more about
Sure.
your
Yeah.
work?
So John Osborne, Clear Cardio is our organization. CLEAR Cardio, CARDIO, clearcardio.com. I'm sure you'll have it on your website, and so people can click
Absolutely.
on that. Also, too, for educational purposes, we do have a Power Up is Prevention Clear Cardio YouTube channel. So lots of cool stuff and educational stuff. If you want to dive deeper into all of this, lots of cool topics we explore, and we have lots of cool patient interviews too, talk about their journey, which are quite interesting as well. So YouTube, Clear Cardio, or clearcardio.com if you're interested in more.
And yeah, all of that is in the show notes here. Anything we did not touch on that you want to get to?
No,
Jason,
I
I didn't
think you
mean to
guys are
interrupt you
brilliant
there.
interviewers. Thank you for doing your research. I think the big topic, the big point is heart disease can be detected early. We have the technology. I would argue, down the road, hopefully not too far longer, cardiac colonoscopy, as I call it, or cardiac CT with AI. And by the way, sometimes people say, who gets AI, who doesn't? Well, everybody gets AI, right?
marketing wise, don't call it a colonoscopy.
Well, I know. But only because people get and understand that, right? And again, colon cancer, we could do this complicated invasive test, 0.1% chance of perforating your colon. Not pleasant, except the propofol's nice with the anesthesia. That's pretty nice. But except for that, the prep kills 2 to 3% of us. Heart disease kills 40% of us. What do we do to find it early? We don't.
Yeah.
So I think we definitely need to catch up in the world of heart disease. It's early detection. Cardiac CT is really the exquisite tool. Calcium scoring's good, right? So if you get a calcium score, it's a great place to start. But if you really 100% want to know, like that old FedEx ad, if it absolutely 100% definitely has to be there tomorrow, cardiac CT with AI, that's now one word, not 2 words, right? Or 3 words. It's cardiac CT with AI, but also too, make sure that it's integrated, not just the data and the imaging, but someone who understands that and then can translate that into a personalized program to stop and eradicate your plaque.
I get
So-
my teeth x-rayed twice a year and it costs
Yeah.
$250 every time. So
Right,
you may as well
right.
do my ticker while you're at it.
Exactly. I think we've seen since we put this together, I've been doing it 30 years. Clear Cardio has been around 2 years. where really our goal is to get this out to everybody. I use the cancer analogy. We want to be widely metastatic and locally invasive. Okay, so we want to be everywhere, and we will. We started in Dallas. We're already in Manhattan. We're in Chicago. We'll be starting here shortly in Miami and Tampa, and then by the end of the year, we'll be into the West Coast. So we're coming. But I think imaging is absolutely critical. If you get sent to your cardiologist because they're worried you might have heart disease because of symptoms, risk factors, family history, or whatever, cholesterol, okay? If they say, well, we're going to start out with an EKG, a stress test, maybe you might get a heart cath, I would just say, look at other options. That's all. I don't want to diss on my colleagues, but that kind of stuff I gave up 20 years ago. Kind of irrelevant when you have this high-tech imaging and AI.
You've made talking about heart disease a lot of fun. Thank you so much for your time.
I
really
will
appreciate
tell
it.
you guys will be the first year. My next career, because I'm going to keep doing what I do till my staff gets tired of changing my diapers and pushing my wheelchair. So it'll be a while. But my next career after that is stand-up cardiology. Okay.
Oh, there
it's a
you
little
go.
tiny niche, stand-up
right.
and cardiology. So
you've got the market
ready.
cornered on that one.
I
Yeah,
appreciate
absolutely.
I'm excited for your sizzle reel.
There you go.
Dr. Osborne, thanks so much for your time. Really appreciate talking
my
to
pleasure. Thanks so much for having me on. And again, I would thank you guys for helping me to eliminate heart disease. I can't do it alone. There are very, very few preventative cardiologists that are doing what we do. I want to get the message out. Thank you for getting the message out. And if you follow that logic far enough, right? My ultimate goal, prevent heart disease, along the way, save lives, prevent strokes and heart attacks. But it's really to prevent cardiovascular disease and eliminate it. And if you follow that logic long enough, really what I'm asking both of you, Jeremy and Jason, to do is please put me out of business. And then I can do stand-up cardiology.
We'll do our best.
Yeah.
We'll do our best.
I appreciate your help.
Thanks so much.
Thank you, guys.
All right, our thanks to Dr. John Osborne. A fascinating conversation. I know that I'm definitely going to be following up and getting my heart checked and doing everything I can to prevent the disease that kills such a large percentage of us without ever being detected early. So our thanks again to him. And if you would like to learn more about him, the work that he does, or get yourself scanned, you can find the links to do so in the episode description for this episode on our website or your favorite podcast player. And our website and that podcast player are where you'll find another episode from us on Monday morning. Thanks so much for listening. We'll talk to you soon.